Okay, guys. How are we doing? It's only a test, right? Nobody's stressing.
Excuse me.
Psych. Okay. So, if you have any questions, I would like participation as much as possible. Because it's just not me talking. If you guys have questions on any subject, speak up or forever hold your peace. Okay, this is the time to speak up if you don't understand anything. The test is 65 questions. It is on Zoom, and it's not, although I did pull up the video on how to do lockdown browser. I haven't done that yet. I don't know. I have to investigate it a little bit longer. I've had to do lockdown browser when I was in for my master's and my doctorate, but I haven't done it on my end yet, like as an instructor. So, and it's going to be at 8:30. Sound good? Okay. You ready? You ready for this? Okay. Peripheral vascular disease. Who has the highest prevalence of hypertension?
Southeastern U.S.
Southeastern U.S. Who else has it? What should say? What? Oh, and I. What? Let's. I was thinking something other than that though.
African Americans, Caucasians, and Hispanics.
That's what I was looking for. Okay. And out of, if you're talking about African Americans, is it the men or the women that are going to have more prevalence of hypertension?
Women.
Women. Very good. And why is it that the African Americans have a highest prevalence of hypertension?
Because the amount of renin that they have.
Exactly. Okay. So, what are some modifiable risk factors?
Obesity.
Okay.
Diet.
Diet.
Dyslipidemia.
So, what are we going to do about that?
Have them do things to lower their cholesterol. So one of those could be medications and then diet.
Okay. What else? What else other than diet can help lower cholesterol?
Exercise.
Exercise. What does exercise do for your cholesterol? For your, I should say, lipid profile.
It gets rid of the fats.
That, and what else does it do? Remember, exercise helps with your HDLs. So if we get them to exercise, it'll increase their, whoops, sorry, I forgot about Melissa. So that's why exercise really helps with the cholesterol and lipid profile. So exercise, even activity, let's just put activity out there, are modifiable risk factors. What are non-modifiable risk factors?
Family history, age, and race.
Yeah. No matter what we do, we can't do that age, can we? We can try all we want. We can do that age thing, but it ain't gonna work. Okay. What are some manifestations of a hypertension?
Headache in the back of the head or neck, dizziness, fatigue, angina, dyspnea, visual disturbances, nosebleed, nausea, vomiting.
That pretty well covers it, doesn't it? But we can sit there and we can put that away. That's why hypertension is so dangerous, because we can sit there and like, I'm nauseous. Well, I had a pitcher of margaritas last night, right? Or I have a bloody nose. Well, I did too much Coke. Just kidding. Well, I could have said I picked my nose too much, but I didn't say that now, did I? I don't know which is worse. But anyway, So, and that's the problem, is we can put it away and not think about anything until they go to the doctor for something like really weird, like maybe they went for the flu and they find out that they're hypertensive, and they'll say, well, I never even knew I was hypertensive. Okay. No, I'll stop there because I'm sure I have it further on down, because you know how I like to talk. What are some? Okay, what diagnostic tools do we use for people with hypertension?
EKG, lipid profile, UA, BMP, CBC, GFR.
Okay. Anything else?
C-reactive protein.
We could do that. Why do we do a UA?
To check the
To
protein in the urine.
Yeah. We look at the proteins in the urine, and we can look at the GFRs, but generally we look for proteins in the urine. Why CBC? I stumped you.
If you have excess hemoglobin, hematocrit, red blood cells.
And that could happen because we have those like polycythemia very patients that basically have to be bloodlet every so often because they have so much blood going on in their system. And you would think that, okay, so when I got out of nursing school, we had these patients that came and we had to like just take their blood off of them. I was like, well, that would be the perfect person to transfuse into another person, right? To sit there, and if they have excess blood, why don't we just give it to somebody that doesn't have enough blood? But it doesn't work that way because there is problems with their blood and their clotting. We just can't give it to Tom, Dick, or Harry. We just basically throw that blood away.
So everything would be high on a CBC, is that what you're saying?
Yeah, for them. Well, it wouldn't be. The white count might not be high. It might be lower because it's diffused. But everything out, the hematocrit, the red blood cells, all that would be high. Okay. What are some lifestyle modifications for our patients?
Weight loss, smoking cessation, reduce stress, DASH diet.
Sounds easy, doesn't it? Whatever. Not that easy. So DASH diet, what are we going to tell them? Oh, please. Hold on one sec. I'm sorry. Ugh. So my dog just got back from the vet from being spayed. We had two of them, one spayed, one neutered. The girl is not handling this well at all. And I imagine she's pissed off at me. But she can't get comfortable, and I'm half tempted to get her a PCA pump. But anyway. She's just freaking. And it's a Chihuahua. They freak anyway. But now she's really, really freaking. Okay. So, what are we gonna, so we said a DASH diet. So what does that entail?
Lower
sodium.
Low sodium. So what does low sodium mean? About how many grams of sodium do you think they should have? And this is not going to be on the test. But what do you think is better? To tell a patient they have to have X amount of sodium, grams of sodium, or to help them figure out what foods they can eat that they like?
Help them figure out what foods.
Yeah, because I think they're going to be more receptive to figure out what foods that they like that they can change than to sit there and like, you can't go above this level of foods. Okay. What about exercise? What do we tell them about exercise?
To move at least 30 minutes, 5 days a week.
Yes. And it can be any kind of movement. What we want them to do is make sure that it becomes a habit. If they have it to where they become a habit, then they're more likely to stick with it. What is malignant hypertension?
Severe like elevation, like 220 over 140.
Yes, it's severe. So why is that an issue?
It can cause organ damage.
Yes. it can.
Stroke.
So what organs are affected by high blood pressure?
Kidneys.
Kidneys?
Liver.
Yes.
Spleen.
It can. You guys are missing the most important muscle of the body.
The heart.
The heart.
Oh my gosh, I'm so hurt. And of course the brain also, right? So it can have all kinds of problems. And let's not even forget our eyes. Because you can have popliteal edema. Okay, so I just did the next question. What are some complications with malignant hypertension? You can stroke out, kidney damage, right? What medications could we give for malignant hypertension?
Hydralazine.
Hydralazine,
Nipride.
nipride. Is nipride an IV medication?
Yes. Drip.
Yep, it is. It is drip.
Nitro drip. Nicardipine push. We can give ACE inhibitors and adrenergic blockers.
Yeah, and all of them can be IV. The ACE inhibitors, the beta blockers, all that can be IV. It's preferable IV because it's going to work a lot faster. It's kind of interesting, like metoprolol, whenever we're giving it to a patient and it's PO, we expect the heart rate to come down and the blood pressure, right? But we can give metoprolol for blood pressure issues. We would give that IV. And what is the goal of hypertensive crisis?
Reduced by no more than 25% in the first hour.
Yeah, because we don't want that rebound effect, right?
So going back to 9 for the beta blockers, would that be IV drip or push?
It'd be a push. Wait, which
Okay.
one?
Number 9,
It's not beta blockers. It's the
The cardine?
adrenergic.
Oh, it would.
Okay.
They generally will all be IV push.
Okay.
Do we have to know if they're all going to be IV push
No,
or
no.
Hey, Becky, with malignant hypertension, is that just the hypertensive crisis or is that the urgency too? Or are those like two different things? I was just getting confused because one gives like parameters, the other one just says it's high.
Yeah, it's about the same thing. And I don't differentiate between the two because no matter what, we're going to treat the two the same. Does that make sense? Oh, I didn't do anything. Oh, poor girl. I mean, she's a little bit of a drama queen anyway, but damn. Okay. So I don't differentiate between the two. Basically, what you're going to see is a blood pressure, and what are we going to do about it? Okay. What kind of medications? And it might be something as simple as, are you going to give a nitro sublingual? Or why would we do a vasodilator for, what kind of medications would we use? A vasodilator? Would we use a beta blocker? I don't even think quite honestly that I put in specific medications. I just say, that we would use so it'd be the difference. So say the question is, patient comes in with malignant hypertension, blood pressure is 220 over 130. let's go 209 over 105. What medications would you expect to use? Beta blocker, ACE inhibitor, let me think of something else. Cardiac glycoside or an anticoagulant. Which one do you it would be a select auto apply. Which ones would you use? I would hope that you wouldn't use a cardiac glycoside because that doesn't affect your blood pressure at all. And well, we could use Lovenox. That's one of those tricky ones. We could use Lovenox, but are we using it to decrease the blood pressure? No. You know what I'm saying? So that's the kind of questions. I'm not real particular on. I figure you guys are taking advanced pharm. Those are the type of questions for advanced pharm. Does that
So
make
since
sense?
metoprolol and labetalol are beta blockers, though, wouldn't you be using the ACEs and beta blockers?
Yes. Yes, you could. And you might be given a labetalol and it might not do crap. So then you have to switch to something else. Okay. It was funny. I told you guys at one point that, doctors ask you what you would do, what you suggest. And I think I was out of school for like 4 weeks. And this hospitalist came up and he goes, okay, wrong scenario. Well, he did ask me that, but another doctor's like, okay, this patient has blood pressure issues. What would you give? And I'm like, blah, 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 blah. 4 weeks out of school, I don't know. I'm like, beta blocker? He's like, oh, I concur. And then we ended up giving labetalol. Okay, hold on, I have some questions. And I just lost my chat. What? Yeah. Okay, hold on. I'm looking at questions. Would you teach lifestyle modifications with malignant or go straight to medications? You would go from malignant, you go right to medications. You have no time for lifestyle. With malignant hypertension, it could be as simple as a patient decided that they no longer want to take their ACE inhibitors or their beta blockers, and it has a rebound effect. Okay. When you're talking about that high of blood pressure, you can't wait for the lifestyle modifications. And that's what a lot of times we see. It's just a rebound effect, or, and it has a lot to do with medication. Not all of them. Some of them have to do with kidney function. If they have something wrong with their kidneys, they'll have the malignant hypertension. But definitely you're going to go for medications first. And then we'll give them the whole song and dance like you really need to take these medications. Okay, you can teach after. Yeah, okay, now Emily, now I read yours. Yeah, okay. It's not been a very good day. Okay. Hypertensive crisis. Okay. What are risk factors for an aneurysm?
Hypertension, CAD, CVA, smoking, hyperlipidemia, obesity, and family history.
Yep, that sounds good. And I'm going to shut up because I know what question I want to ask you, but it's further on down. What are some signs and symptoms of a thoracic aneurysm?
Back, neck pain, substernal pain, dyspnea, stridor, brassy cough, hoarseness, dysphagia, edema of face and neck, distended neck veins.
Well, yeah, you about well covered it all. Now remember, they can have these aneurysms and not have any problems whatsoever. The key is if they now are reporting that they have, they're having trouble swallowing, they have back pain, we are safe to assume that it has gotten larger. Okay. They're not necessarily going to have it because quite honestly, if they start having that back pain, that means that aneurysm's large enough probably to be operated on. Okay, now what's the signs and symptoms of abdominal aneurysm?
Pulsating abdominal mass, mild to mid-abdominal lumbar back pain, cool cyanotic extremities.
Sounds pretty good.
And claudication.
Could have claudication also.
Aortic calcification on X-ray.
There you got it. What was I gonna say? I was gonna say something, I don't know. Okay, when do we do surgery for aneurysms?
If they have a dissection or if it's over 5 centimeters.
Right, if it's over 5 centimeters, is it 5 centimeters or 5.5?
5.5.
Okay. Okay, then we do surgery on it. How do we manage an aneurysm with medication? So it's not large enough yet.
Long-term beta blocker therapy.
Okay. What else?
Antihypertensives like statins, and then lifestyle modifications.
Okay. So basically we want to keep all that plaque and it from building up on the sides of the walls, right? And causing more of a vessel issue, correct? Did you just lick that peanut butter? Sorry. I won't call you guys out on your Zooms. Okay. So we're really looking for blood pressure issues, right? But we're going to give them statins to help with that also. How do we diagnose? What? Go ahead.
I know we do yearly monitoring when it's stable, but in class, didn't she mention that we would want to monitor like every 3 or 6 months or something?
So we'll monitor it every 6 months for the first year, and then we'll go yearly. Okay. And how do we diagnose the aneurysm?
A chest X-ray,
Could be a chest X-ray. What else?
abdominal ultrasound.
Ultrasound.
Abdominal ultrasound. That's usually how we catch it. Abdominal ultrasound or a what else will catch it?
TEE.
A TEE, especially if it's close to the heart. There's one other one we would look at.
CT or an MRI.
Yeah, CT is usually what we get. And it's usually we're looking for something else and then find it, is what happens. Don't cut out your ultrasounds, guys. Okay, ultrasounds, although they're like people think that, oh, it's just an ultrasound, it picks up a lot of things that your CT won't. Okay, so I had an argument the one time with, it wasn't an argument, but I thought she was a pissant. My husband was having issues, he was having pain, and they sent him to CT, didn't find anything. I said, what about an ultrasound? What do you think? And she said this to me, what do you think an ultrasound's gonna show? I said, well, gallstones, enlarged gallbladder. And she's like, no. I'm like, you can't see my eyes, but I was like, oh, I want to throat punch her. So they admitted him for pain. He ended up on a Protonix drip, a banana bag. And if you guys know what banana bags are, they're for alcoholics, and he doesn't even drink. And I'm not saying that as a denial thing. No, he doesn't drink. A banana bag, Protonix drip, which they hooked up wrong. He went down for an EGD. An EGD. And I'm like, can't we just get an ultrasound? They said, no, the ultrasound's not going to show anything. So they sent him down to an EGD, didn't find anything, but kept him on a protonic strip. Then they're like, well, we're going to repeat the CT tomorrow. I'm like, what about an ultrasound? Finally, the doctor's like, are you serious? That's all you want? I'm like, just an ultrasound. So it was a Friday. And if they didn't do it that day, they were going to have to wait for 2 days before the ultrasound tech came back on Monday. I'm like, all I want is an ultrasound. So ultrasound tech came up. Guess what they found? Oh, the gallbladder was enlarged and he had all kinds of stones in there. I wanted to go walk down to that ER and throat punch that nurse and say, that's what an ultrasound shows. All this money that I just spent, and it was an ultrasound. So that's my bitching. So don't count out back in the old days, okay? Ultrasounds are very important for us. Okay. What would we, if a patient came in, what signs and symptoms would we look at or look for a dissection or a rupture?
Sudden excruciating pain, difficulty breathing, fall in blood pressure, absent peripheral pulses, chest and back pain, like a ripping and tearing sensation over the area that had the dissection.
Why would you think that there would be the peripheral pulses would be absent?
Because all the blood's rushing to the injury.
Yes.
And like escaping the body.
Yeah, so there's no oxygenated blood going down to their peripherals. Okay, that's why you wouldn't have any. So I just want you guys to understand why they wouldn't have pedal pulses. Okay, it's because there's no blood going down there. It's pooling in the abdomen or in their thoracic cavity, wherever it is. Or if it's close enough to the heart and to the pericardium, it might be just going, going into the pericardium. So I want you to understand why they wouldn't have pedal pulses. What's the one thing we want to do with these folks that came in?
Get them straight to surgery as fast as possible.
Yeah, we're going to put a line in them. We're going to put as many lines, at least a big bore, like 18 gauge, 16 gauges, because we're going to need all kinds of fluids going on them. We definitely don't want to wait to put that IV on. Their veins will collapse and we won't have anything. Very little time do you have for an aneurysm. Okay. We got to do it quick. Okay. So a patient came back from surgery and they had an aneurysm repair. What are some of the signs and symptoms of a complication?
Ecchymosis, increased abdominal girth, weak pulses, fall in hemoglobin and hematocrit, increased pain, and decreased urinary output.
Okay. So on the vital signs, what are we looking at there's a complication?
Increased blood pressure.
Increased blood pressure. We're actually looking at both of them, right? We're worried about the increased blood pressure, but we're really worried also about a decrease in blood pressure. Because what happens if it gets too high?
It can start.
It can bust the repair.
Yeah, it can blow the graft. Okay, or cause the graft to leak. So we're worried about the blood pressure. We don't want it too high, but if it's too low, then we're worried about them hemorrhaging. Okay. So yeah, well, Alexa, you pretty well covered all of them, I think. I don't think there was
Can I ask a
any.
question?
No.
I'm going to.
Okay.
So what exactly, can you just explain a little bit more like what the difference between an aneurysm and like the dissection is?
So the dissection is that the aneurysm is pulling apart.
So like it's like ruptured?
Okay. So a lot of times these aneurysms happen around bifurcations. So your bifurcation is like a little where the artery splits. Okay. So what could happen is that right in that where that bifurcation is, it can dissect, pull away. Okay. That's what it means by really dissecting. It's kind of hard. it's all about the language, because you can have an aneurysm leak. When you think of rupture, it means that it just blew. Okay. When you're talking about leaking, or I'm trying to think of the other word. There's another word. Which basically means you have time. Like if an appendix ruptures, you're in a lot of crap, right? Because it goes into your period. But I can't think of the other word. But if it, and what it means is there's an opening and it's leaking out slowly into the surrounding tissue. I can't think of it. But the rupture is the bad one, because it there she blows. It blows up and the contents gets everywhere. When you're talking about an aneurysm rupture, that's what's going on. It ruptures and the blood, all that blood is just pumping into the surrounding tissues. So you don't want to rupture. When you're having a dissection, you have a little bit more time, because you might just have a small leak when it comes to that. You're still having blood come out and you really have to do something quick, but it's not a rupture. Does that make sense?
Yeah.
Does
it does.
dissection happen more frequently than rupture?
I can tell you hear more about ruptures because those are the people that die. Those are the people that can't get to the hospital we can't save. Dissection, I would think we have a little bit more time, because you have that pain beforehand and they continually have that pain. So I would say dissection, you basically have more time to work. Not much more time, but you have more time to work. But with a rupture, you hear more of them because of people, like I said, those are the ones that, you hear on TV or you see on Facebook. Okay? Wouldn't
Can I
that
ask
be a
a
nice one?
question?
What?
Okay, the decreased urinary output, is that just because, like, if they do have a hemorrhage, the kidneys aren't being perfused like they should?
It could be two reasons. Could be because we hit the renal artery, or it's because of the fact that their kidneys aren't being perfused. Either scenario is not a good scenario. Okay.
Thanks.
No problem. But you would see, so either way, your blood pressure would go down, but then your heart rate would go up. So you would almost have to find out what's going on. So in that case, so we have decreased urine output. How would we be able to differentiate between the two? Between nicking the renal arteries, or the fact that, they're just hemorrhaging somewhere else? That's a stupid question. Either way, the CBC would be messed up. Either way, they're hemorrhaging.
If the renal artery was nicked, would there be blood in the urine, or is that too far,
No,
kind of?
no, it would go in the surrounding areas, because I would not expect it to be in the urine, due to the fact that you nick the artery, so the blood's going to the surrounding tissues and not through the kidneys. And then your urine is protected so much, by your bladder, so it wouldn't go in there also. So, and the reason I was asking that, Holland, was I was like, well, how could you tell between the, nick and it being because of the fact that you're bleeding, from the graft, or bleeding from the renal artery, but it would be the same. You would have to, either way, it's a complication, and we would have to find, probably have to go in and do exploratory surgery to figure it out. I mean, they could probably do an ultrasound, but do they want to wait to do an ultrasound? They probably want to get them to the surgery as fast as possible. Well, that's a good question, though. Good question. Okay. Anybody else on aneurysms?
For number 16, like how we diagnose it, is it just by the ultrasound, or do we do like the chest X-ray and TEE and all that too?
So in the case of like my dad, he went in for shortness of breath and he did a chest X or a CT of the chest. And that's how they found it. Could you see it on an X-ray? Possibly, if it was large enough, you'd be able to see it. But a lot of times it's CT or an ultrasound, an echo, an ETEE. So I don't want to say, like, I would say the majority of the time it's found by accident. You know, where maybe you're having shortness of breath, so we do a CT, or you're going to have surgery, so we do an X-ray. I don't know any instance that we would sit there and like, we think you have an aortic aneurysm. Do you know what I'm saying? It's because when they're small, you don't have any symptoms, so there's no reason to look for it. If you come to us and you say, I have this bloating, abdominal bloating, I don't know what's going on, it's just uncomfortable, we'll do a CT of the abdomen and find it that way. But it's just usually they're so small, you don't have any symptoms until you come back and you're like, now I have symptoms, now we'll find it. But aneurysms, we don't generally go out and find. Does that make any sense? Okay.
It does.
Okay. It's kind of like you expect to have, I don't know, GERD, and all of a sudden, nope, you have an aortic aneurysm. That'd be a bad day. Bad day. When do we do surgery? Been there, done that. Okay. And it's really important to look at the pedal pulses, okay, when they come back, because we want to make sure they're getting blood flow down there. So pedal pulses and making sure about the blood pressure. Okay. And we talked about, do we want them to have blood pressure, high blood pressure? No. And we talked about the post-op complications, right? About the renal, about them bleeding through their grafts. Is there any other complications they possibly could have, do you think?
Bowel ischemia.
EKG changes, chest pain.
EKG changes, chest pain.
Bowel ischemia.
What was that?
Bowel ischemia.
Yeah, bowel ischemia. So those are all complications that they could possibly have. Now, as nurses, what complications could we see as a post-op patient? Let's go back to the basics.
Hemorrhage.
Hemorrhage.
DVT and pneumonia.
DVT and pneumonia. Okay, so we're very careful. Especially with the pneumonia. With these opens, we cut them open, right? So it's gonna hurt like hell. So they're not gonna want to deep breathe. So let's go back to our lovely care plan. So we want them to cough, deep breathe, right? And send spirometer. What else? To make sure they're not getting pneumonia.
Sit them up.
Ambulate.
Sit them up, ambulate. What else?
Oral care.
Oh, thank you, Taylor. Oral care. Remember that bacteria in your mouth, if it doesn't go anywhere, it goes down into your lungs. So oral care is very important. Okay. And so we opened them up. So we're giving medication because we sawed open their chest, and they can have a DVT. So we know about what we can do for that, right? Heparin, Lovenox. What else?
Ambulation.
Ambulation,
SCDs.
SCDs, and let's not forget our good old TED hose. I tell you what, those those gynecologists, they do not play with DVTs, because you have a gynae, post-op, they're getting heparin or Lovenox, they have their TED hose, and they have their SCDs. They don't play with DVTs up there on the OB floor. One other thing that could have a problem. And we're giving pain meds.
Constipation.
Constipation.
Yes, constipation. You don't want your patient to be constipated. Because what happens if they're trying to have a bowel movement and they just can't get it done?
Vagal down.
Yep, they vagal down. And we already messed with the heart once that day, right? Or recently. The last thing we want them to do is vagal down and go into a dysrhythmia. So we'll make sure they have that colace. Okay. So, any other questions on aneurysms or hypertension? Don't yawn, man. Make me yawn. What do you guys think? Are we good with that? Okay, let's go on. Oh, wait. Okay. Signs and symptoms of PAD. What do you think?
Calf pain, weakness, relieved with rest, burning at rest, paresthesia, diminished pulses, pale legs, but they're rubor when dependent, thin, shiny, hairless,
Okay.
discolored skin and lesions.
Okay. What was I going to say? Well, let's do what's some complications of PAD.
Gangrene.
Gangrene's one.
Complete arterial occlusion, extremity amputation, rupture of AAA. Is that ascending aortic aneurysm?
It's actually abdominal aortic aneurysm.
Oh, that makes more sense.
Why would that be a complication?
The plumbing was blocked, so it puts pressure on the aneurysm wall.
Oh my God, you sound like me. The plumbing. Hey, whatever works. The plumbing is blocked. Yes, the plumbing is blocked. So what happens? It backs up and puts more pressure on the aneurysm wall. Very good. Could these patients have chronic pain?
Yes.
Okay, they can have chronic pain. It just gets worse when they're trying to walk. Okay, they start walking. Of course, they have the angina to the legs, and they stop and they go back to their baseline. So yes, they can have chronic pain. If a patient comes to you with a history of intermittent claudication, but now is complaining of unrelieved pain, what would your diagnosis be?
Acute arterial occlusion.
Yes, they're looking at an occlusion. Okay. What would you expect to see from that patient? So if they came into you and they have an acute arterial occlusion, what would you expect?
No pulses on their
Right, no pulses. How would the feet feel?
Cold.
Yes, they would be very cold. Okay. So what are you going to do?
IV heparin.
Yeah, we're going to start with them on an IV heparin. What happens if we don't have, I don't know, for whatever reason, we don't have IV heparin? What's something else we can do right away? I wouldn't say right away, but after they do the 26 questionnaire, what can we give them that would help?
Fibrinolytics.
Yeah, thrombolytics. Okay, because that can that will just bust that clot. Okay, they can also, but this isn't going to be on a test. They can, if depending where it's at, they can put the fibrolytic right against the clot, so it doesn't have to be systematic. It'd just be like right there. So no pedal pulses, cold. Do you think I'd be painful? They're gonna tell you that it's very painful. Okay, so we got to get something done. What happens if we don't get it done? What happens if we're like, don't got time for you? What would happen?
Gangrene.
It would be even more acute than that. I mean, eventually you'll have gangrene, but if it's not getting any oxygen down, what's going to happen to the feet?
Necrosis.
Yeah. So you only have so much time before the cells start to die. And if the cells start to die, then you're going to have more tissue dying. So if they're that injured, then we're going to start having to amputate.
Is gangrene a bacterial infection that just gets way worse because they're not getting any blood flow to their feet?
That's correct.
Okay.
It smells. Anybody smelled the gangrene?
Yeah.
Yeah, I would take a C. diff over a gangrene any day. You will get some patients though that for whatever reason they're not going to chop anything off, and it's kind of weird. The toe blackens, and then it just shrivels up, and then just falls off, which sometimes is kind of like shocking if you like pull back the covers and there's the toe. But
that happened to me with a finger.
Oh, it did?
Yeah, like the tip of it, like it was just like hanging there. And then I went back and the dude was like, here's the tip of my finger. And I was like, oh my God.
Well, thank you.
Yeah.
Thank you for your tip of your finger. Well, at least he gave it to you. He didn't like just put it as a joke,
Yeah, it was disgusting. He lost his whole hand. So
Really?
yeah, it was nasty.
How come he lost his whole hand?
I don't know. He was homeless and he had like maggots and stuff, and then they got all that taken care of. And then the fingers were like really bad, and then they were like his palm, like he couldn't move his hand at all. It was bad. It was in Greenville whenever I did clinical.
That's just
it was crazy. Like his hand, it looked like a skeleton hand. Looked like something out of Pirates of the Caribbean, to be completely honest. It was nasty.
But cool.
It was kind of cool. It stunk, but it's kind of cool.
Yeah, they say that maggots, it's not uncommon anymore, it seems.
Gross.
Yeah. Yeah, especially if you hear them eating. But anyway, we're not talking about that. Okay, so we're going to do heparin. We can also do an embolectomy, which goes in and retrieves that clot if we have to. But that's usually on a very large artery. Come on. How are we going to treat PAD? What medications?
Antiplatelets.
Yes, antiplatelets.
Pain control.
Pain control.
Nursing things would be teaching them smoking cessation, proper exercise, and foot care.
Yeah. Why foot care?
Because the blood's not getting down to the feet well. So if there's wounds on if you get a wound on your foot and your feet are not clean, that's infection easy. And then the blood's not getting there to heal it. So
Yeah,
it would.
that's exactly it. What about, what could promote blood flow down to the feet?
Vasodilators.
Vasodilators.
Dangle your feet.
What was that?
Dangle your feet.
Dangling your feet. What else?
Surgical revascularization.
We can do surgical revascularization. What could the patient do, you think?
Exercise.
Exercise can help.
Stop smoking.
Yeah.
Low
Unfortunately, a lot of
cholesterol
our,
and
what was that?
low cholesterol and fat diet.
Yeah, low cholesterol, low salt diet. A lot of our folks that have the revascularization, they don't quit smoking. But I wish we had more, because more cases, because I was used to love sending students. I'm like, now find out why they had it. And 99.99% of the time it's because they were smokers. But there's one other thing. What causes vasodilation? Other than taking vasodilators?
Warmth.
Warmth. Are we going to tell them, well, we want you to keep your feet warm, so why don't you, a good idea is to get a heating pad and put a heating pad on your feet.
No,
Well, why not?
because they can't feel it and then they can burn their feet.
Ah, that's it exactly. Okay, so we want them to have nice, socks. Socks would be great. We want to keep them, make sure they have something on their feet, shoes when they're going around the house. But we definitely want them to keep their feet warm, but we don't want them to use heating pads. Okay. It helps. It's not the best. I'm sure the heating pads would work a lot better, but they can't feel it, so they can't feel if their feet get burnt. Okay. And we definitely want them to dangle their feet. What are you gonna do? How are we gonna treat? And what is the ankle brachial index?
It's the ratio of the blood pressure at the ankle to the ratio of the blood pressure in the upper arm. Compared to the arm, if it's lower in the leg, it indicates blocked arteries related to PAD.
There you go. There you go. Oh, did I screw up? Yeah, and that's exactly it. And that's one way we can tell about PAD. Other than the signs and symptoms, that's a definitive test that points right to PAD. Okay.
And you said we don't need to know the specific numbers for that, do we?
No. Okay. And why did I put that? What are some signs and symptoms of PAD? Must be on crack. Okay, so what is some nursing management acute care of a patient with PAD?
Frequent pulse assessment, bed cradle, like an egg crate or heel protector, keep the extremities warm, education, allow them to keep their extremities dependent, increase activities as tolerated.
Very good. Holy crap.
Hey Becky, whenever they say keep your extremities like dependent, do they mean like walking on them, or do they mean like what exactly?
So it would be like not having, if you notice our chairs at our hospitals, you can put the feet up, but they're not up like a lazy boy. And that's for our patients that have PAD. So they're still lower. You want the bed to be lower. So so it's not exactly flat, but a little bit lower. I mean, just things like that. Sitting them in the chair, making sure their feet are lower than their heart, and also in the bed, make sure that their heart is higher than their feet, just to give them a little bit of an angle.
Okay.
Okay. Gosh darn it. And with these folks, guys, don't do those pillows. You know how we try to float people's feet with those pillows? Let's face it, pillows at the hospitals suck. Okay. If you have a patient that has severe PAD, then get out the heel protectors. Okay. Because floating is not going to, you don't want it sitting on the bed, and that's what the egg crates are for and everything like that. But don't do the pillows. I mean, those pillows, they're horrible.
So for the heel protectors, is that like the blue thing?
The what?
The blue thing, I don't know how to describe it.
I think ours are blue.
Is it kind of like a pillow, but not?
No, it's foam, and it surrounds their foot on both feet. It surrounds their foot, and you buckle it in.
Okay.
Some don't like it because they can't like roll around as much, but it stops them from having any deep tissue injuries on their heels, which is a real big problem with PADs, patients with PAD. What would you say? No. Okay. Anyway, what kind of medications would these patients be on? Or did
Plavix.
Plavix? Very good. If they're on Plavix, what else are they going to be on? It's another antiplatelet.
Aspirin?
Yes. Remember, whatever they're going to be on for coronary artery disease, they're basically going to be on there for peripheral artery disease.
For
So
aspirin, would that be
aspirin.
81 or 325?
I think everybody's pretty much on 81 anymore.
Okay.
We used to do 325 whenever people got stents. But then they found out there was no benefit for that, so everybody got knocked back down to 81. So antiplatelet. What else could they be on?
Would they be on pain medication and stuff, even if it wasn't like if they weren't in the hospital having some acute episode of it?
Yeah, they could be on pain medicine for sure.
For like the pain medicine, will we be giving them like morphine, or will we be giving like a lower dose like ibuprofen or something?
So if they were in the hospital and they had an occlusion, definitely would be giving them morphine. If it's at home, it's going to be about their pain levels. They probably would start off with Tylenol and then go up to 325, and then until if it gets bad enough, I've seen fentanyl patches. So it really depends on the severity of their pain.
Should we expect a stool softener with that?
Oh, hell yeah. Or heck yeah. What else? What else do we give our folks that have coronary artery disease?
Lipid lowering agent.
Yes. So we're going to do lipid lowering agents. And we're going to do some, we said vasodilators, and we were talking about it, it's like more like isoboride, mononitrate. But what else can we do to possibly open up those vessels down that way?
ACE?
Close. We could try a beta blocker to see if that would help. because it decreases your afterload, decreases, opens up the vessels just a little bit. I wouldn't say opens, I say relax. Okay, sounds
Would we
good.
be giving those IV?
No, acutely. So if it's acute, not really. Probably not. We could acutely, so if they come to us and they are having an acute occlusion, it's more, when I was talking about this, is more like take home meds that we would be doing it at home. Hold on one second. Okay. Oh, what happens if you can't find a pedal pulse? How do you document that?
You need to get a Doppler to make sure it's actually not there first.
Thank you. Yes. So don't just document, oh, can't find a pedal pulse. Sucks to be you, right? No, we have to get a Doppler. And there's actually a thing on there, Dopplered. So that's how they know that, that's how you got your pedal pulse. But if you don't have any pedal pulse, even with the Doppler, you better call somebody. Okay, you just don't let it go. Okay. And we talked about the risk factors for PAD, right? And what are the 6 Ps?
Pain, pulselessness, pallor, paresthesia, paralysis. And how do you say the other one that means cold?
I wish you would see my eyes. Do you hear me talk? And you think I can say polyctherapy?
What does that mean?
It means they're cold.
Yeah.
Well,
Why doesn't it just say cold then? Like, why do we have all these crazy words?
because
Why
they
They
can't we
want
just say cold?
6 Ps.
Because people have to
ridiculous.
make themselves feel more important.
Why can't it be like 5 P's and a C?
That's what Karen said.
I don't know, but Veronica's funny. How do you say that? I wish I had a better camera. A new camera costs so much. It's like $150 for a new camera or something like that. Maybe. And now freaking Walmart's not having their Black Friday sale, so I can't elbow anybody to get a new computer. That was the funnest part about the whole Black Friday. I didn't care. Just to let you know, Thanksgiving is not for vegetarians. We really don't care about Thanksgiving. Okay. But we cared about the Black Friday shopping. But anyway.
Amazon has some pretty good deals.
That's no fun. Who are you going to elbow?
You have kids.
And you know what? I never even went to Centralia. We go to Centralia at 9:00. We would go to Mount Vernon because the people are a little bit more rowdy at Mount Vernon. Like, was it last year? Somebody went around with a taser, and you wouldn't believe how fast people got out of her way. I mean, you hear the bzz, 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 people just jumped out of her way. I mean, it was just awesome. And I would just sit there and watch them. I mean, that was great. I mean, I like to people watch, and Black Friday at Walmart is the best people watching. And then you see everybody from the hospital come over and we just chit chat. It was, I don't know. I mean, there's better places to chit chat, but it was fun. And Kohl's had a great sale too. But anyway, but I don't think I'm going to get a new computer because I'll have to look on Amazon, I guess. My husband's good on Amazon. I'm not. You guys are nice and clear and I'm just like foggy. So you can't even see my eyes. So when I roll my eyes, you can't even see me roll my eyes. It's kind of frustrating. So 6 Ps, very important. And you guys are going to see that it's very important when you're going to, when you go into ortho neuro. because whenever we're talking about compartment syndrome, we're talking about the 6 Ps. Okay, so the neuro assessments are very important. Okay, what's the difference between an occlusion and a venous thrombus? And when I say that, arterial occlusion versus venous thrombus. Well, there's one obvious difference.
One's
Artery
in the
versus
artery,
vein.
one's in the vein.
Yeah, one's in the artery, one's in the vein. But whenever we're talking about arterial occlusion, what are we expecting that occlusion to be made up of?
Plaque.
Yes, it can be plaque. It can be a little, a little bit of a blood clot, but a lot of times it's plaque that occludes the artery. Okay, when we talk about a venous thrombus, what are we talking about?
Blood cells.
Yeah, what are the blood cells doing?
Coagulating.
Ah, there you go. And that's why we need anticoagulants. Okay, when we're talking about the arteries, what a lot of times happens is a part of the plaque that gets dislodged and it can cause an occlusion, or that part that gets dislodged, the platelets go, oh crap, we got to fix it. So then they start not coagulating, I don't want to say aggregating. So we got to fix, we got to fix, we got to fix. And that causes occlusion. That's why we use antiplatelets, to make sure that if there happens to be an injury to that vessel, the platelets can aggregate, can form that basic clot. With venous thrombus, we're looking at anticoagulation. We don't want those blood cells to be able to coagulate and cause a thrombus. Okay, so that's
So
the big difference.
So antiplatelet for arterial and then anticoagulant for venous?
Yes. Yes, yes, yes. Okay, so that's the big difference. So if you have, say you have a thrombus, so you have a venous thrombus, what could be a complication of a venous thrombus?
Pulmonary embolism.
Yes, a pulmonary embolism. On the other end, and it's if you have we're talking PVD, forget that scenario. But if we're talking about any kind of occlusion or a thrombus in the left side of the heart, then we can assume that, or not assume, but the biggest complication is a stroke. That's why when we're talking about AFib or heart failure, we're very careful for them not to get strokes. We give them anticoagulants. That kind of like just threw up in my face. That was wrong. I was thinking the wrong way. If it's the left side of the heart, a thrombus can cause a stroke. If it's in the periphery, then the thrombus could cause a PE. Sorry, I don't know where I was going. Does that make sense? Left side of the heart.
Say that one more time.
So if it's on the left side of the heart, if you have a thrombus on the left side of the heart, a complication of a thrombus on the left side of the heart is a stroke. So heart failure, AFib, anything like that. If it is a thrombus on the right, on the periphery, then your complication is a PE. And if you think about the way it goes, your left side of the heart, where will it go? The biggest complication is up into your brain. If it goes down into your periphery and you have a DVT, what happens? It goes up into your heart, because it can go through your heart, but what the problem will be is in your lungs. I see y'all confused. Does that make any sense?
So if there was for an arterial occlusion, if that occlusion broke off, what would we be concerned about then? Does that make sense?
It makes sense. And that's where I screwed you guys up. because I was thinking it, but I misspoke. I would think at that point in time, the biggest thing you would worry about it can't. If you have an arterial occlusion, it won't do anything but be an arterial occlusion. Because if you think about it, it has to go through the capillaries before it gets into the veins. So you're not going to have that plaque that goes through the capillaries into the veins. There's like no real, because it's too big for that to happen. That's why it will stay in an arterial occlusion. A DVT, on the other hand, can go up in through, happen in your, in your legs. It can go up into your heart and then it gets lodged into your lungs. And why does it get lodged into your lungs? Well, because it can come up and it gets into your lungs and it can't get through into, it can't get through that capillary space. I don't want to say capillary space, we haven't gotten there yet, but it can't go, it goes large, smaller, and then small, and it gets stuck right in that small spot, to put it even. So it can't go back into your heart once it hits the lungs. Does that make any sense?
Yeah.
I'm looking at faces. But you can't look at mine because my camera sucks. So, and the reason I want you guys to get through that is, well, we had that test question, about the mitral valve stenosis and, what complication it was, and it was a stroke. Okay. You're going to see more questions about DVT and what's the complication of a DVT. And it's just, you have to understand there's a separation between like church and state right there. That if you have a DVT, that you're not going to get a stroke. Okay, there's no way for that DVT in your peripheral legs to get into your brain the way the circulatory system goes. You guys got that?
So it's just dependent on like if it's coming from your heart going out or if it's coming back up, which is going to get into your lungs.
Exactly. Okay. You guys got that? Somebody nod. Okay, Emily, just smile. Don't nod. Oh, I gotcha. Okay. Where are we? Okay, signs and I got that one. PAD, 6Ps, got that. What's a complicated? Well, hell, I just gave you a 15-minute synopsis of what is a complication of a thrombosis. A PE, right? What are some risk factors for a DVT?
Sedentary lifestyle, surgery.
Okay.
Cancers, trauma, pregnancy, hormone replacement, oral contraceptives.
Yeah, those are the big ones, right? What about dehydration? Would you think dehydration could cause a DVT?
Yes.
You didn't sound, you're like, yes. Okay, so, and it's not in itself going to cause a DVT, but why would dehydration be a factor into DVT?
Because there's less circulating blood volume.
Less circulating blood volume, there's less, the blood is not
More
as fluid.
concentrated.
Yeah, it's more concentrated, good word. Yeah, there's not as much fluid as there should be, it's a lot more concentrated, so it has more of a coagulability. So patients that are dehydrated or patients that are we have to make sure their hydration status, is basically stable. Okay. So that could be a risk factor also. But basically sedentary lifestyle is a big problem. I don't know. Do you guys watch 600 Pound Life? You don't? Molly, you don't? Oh my gosh, Alexa, you people need to get off of Hulu and everything. So a lot of these patients for 600 Pound Life, they start off in like Illinois and they have to drive down to Houston. A couple of times what happened was by the time they got down to Houston, from where they ended up with DVTs because of the fact that how they were sitting in their cars and taking so much, it took too much time for them, and they're sedentary anyway. But dehydration and the sedentary and staying in one position for so long caused them to have a DVT. Okay, what's Vicro's triad?
Stasis of blood, vessel damage, increased coagulability.
Yes, and you'll see that over and over and over again. Okay. What is the manifestation for superficial venous thrombus?
Localized pain, tenderness over the affected vein, redness, warmth over length of vein, palpable cord along vein, swelling, redness around the tissue.
And what does that sound like? What other diagnosis could that be?
Infection.
Cellulitis. So, how can we tell the difference between cellulitis and a thrombus?
Distal pulsus.
We're talking about venous.
Would a CBC like the white blood cell count?
That could be something. What about an ultrasound? So if they do an ultrasound and they put the ultrasound over that reddened area, they should be able to see a thrombus. If they don't see a thrombus, then we can go and say, you know what, it's cellulitis. Okay, so we would still do the CBC, but until we could get an ultrasound, we treat it like cellulitis, but we really need that differentiation.
I don't remember much about what was going on with my patient, but one of the first patients I had for this rotation, I don't remember why, but she had been sedentary for a while. So when I was there, they did an ultrasound of her lower extremities to look for clots, and she ended up having one per leg.
Oh, I'm trying to think which patient that was. Do you remember what room?
I don't remember what room specifically, but I know it's the room right by the stairs.
Yeah, it was 3224.
Yeah.
Yeah, because I remember, because she was a bigger lady. Yeah, okay. She ended up being discharged, didn't she? Was it that day or Wednesday? I'm trying to think.
I had her Wednesday, so I'm not sure when she was
that's
discharged.
Right. Okay, and that's probably what the reason. I mean, she had a hard time getting around. So, yeah, definitely. But she had COVID at one
Yep,
point
she
in
did.
time. Okay. Well, that explains it. And you know what? With that COVID, a lot of the problems we're having is the fact that they have increased coagulability and they're throwing PEs. So a lot of the patients, I wish we could see our patients. I do, but I don't. But you'll see, and those that work with COVID patients, I could be wrong. You guys that work in Memorial, do you see patients? Which I don't see anybody that works in Memorial. They're probably working. Anyway, what you'll see is that we don't do like pneumonia. If you have pneumonia or flu, we're giving you fluids. But with our COVID patients, we can't give them fluids because of the decomposition compensation of the heart and of the kidneys. So we can't like give you fluids to break up that pneumonia that's in your lungs. What we're giving them, what you see is we're giving them heparin. And one of the problems we're having with that heparin is it's causing bleeding, retroperitoneal bleeds. So it's kind of like a dance at this point in time. The last couple of people that have passed away were because of hemorrhaging and not necessarily the COVID, but it's one of those complications of COVID. Okay. So that's why it was funny because Sharon and I were talking. I'm like, I'm not even teaching about COVID because Lord knows we don't know enough about COVID to even teach. Unfortunately, I probably won't be able to teach it for another 2 or 3 years because of everything that's going on, and I don't even know where to start, quite honestly. Okay, manifestations of a DVT.
They could be asymptomatic, dull aching pain in the affected extremity, especially while walking, tenderness, warmth, erythema along the vein, dilated superficial veins, edema of the affected extremity. Complications would be pulmonary embolus and chronic venous insufficiency.
Okay, so what we're looking at is a blockage of the veins. So anything that reminds you or would consider the blockage of that pump, that the plumbing, is what we're going to see. Okay, so they could have edema. They're going to have some pain, and some people don't really have any pain. They'll come and say, "Yeah, I have a DVT again." Well, how the heck do you know that? Well, I have that uncomfortable feeling in my leg. Okay. How do we diagnose a DVT?
Duplex
Ultrasound.
venous,
What was that? Ultrasound?
duplex venous ultrasonography.
Yeah, that's it. Gotta love those ultrasounds. How can we stop our patient from getting a DVT?
Prophylactic heparin use to elevate the leg to promote venous return, early mobilization and leg exercises, and intermittent pneumatic stockings and TEDOs.
Yeah. Get them up and start walking, right? So anything it is to get that blood flow back to the heart is what we're looking at. What precipitating factors could lead to venous insufficiency? What was I thinking when I wrote that one?
DVT, varicose veins, leg trauma, or
That's what.
unknown.
Okay, you got me. That's what I was thinking. What is the difference between veins and arteries? And I don't mean, one has the oxygenated blood, the other has the unoxygenated blood. We're looking at structures.
Veins have valves.
Right. They have valves. The veins have valves. And a lot of times what happens is those valves don't work anymore. And so those valves help the blood get back up to the heart. When those valves fail, then that's when you're going to see more issues with PVD. Okay, what are manifestations of venous insufficiency?
Lower leg edema, itching, discomfort with prolonged standing, cyanotic or brownish discoloration, stasis ulcers, possibly weeping, thickened skin, deeply pigmented, scaly appearance.
Yes, very good. And no matter what
Actually,
you
I
do,
have a question. Oh, sorry.
sure, go ahead.
I was gonna say, I thought so. Usually, doesn't the bluish and cyanotic come in with PADs rather than the PVDs? That's
So-
the part I get confused about.
So you see a little, I think it's more like bluish purplish when you're talking about PAD. I think what you'll really see the difference of, and with PVD, so PAD is caused because of lack of blood flow getting down there. So that's where you get your bluish. And a lot of times your skin kind of gets, you'll see the skin gets stained almost with it. I don't know how to really, how do I want to say stained? It's not, when I think about it, it's like around the calves that you'll see that bluish tint the, you know, the discoloration. Okay. When you're talking about PVD, you're talking about the whole foot. Like the whole foot up into the calf has that rubor, reddish, bluish. And the reason it's more bluish on the venous side, I would say is more bluish, is because the blood is pooling and it's unoxygenated blood. And I want to say kind of like, I don't know, garbage blood. I don't want to say garbage blood, but basically that's what unoxygenated blood is, right? Garbage blood, because there's no use for it. But the skin, it's a lot different of a colorization. It's deeper colorization. And I wish I had some photos to pull
So
up.
PAD is superficial, PVD is deep.
Yeah, that you said it better than I did. Like if you just, I'll put some pictures up that you can see
I'm
the
just thinking that
difference.
like PVD is supposed to be the rubor, like it's red, so you think it'd be like super red and edemacious, but then it says cyanotic, so that's what I'm getting confused at.
Well, it's cyanotic because of the fact that there's no blood flow. Like there's not there the blood that's down there is crap blood. It's red, so there's where your rubor is. But then not because of the so much swelling down there, you still get pulse and you still get arterial blood flow down there, but it's not as prevalent. Does that make sense? Because there's not enough room.
So are you seeing the red and the cyanotic? That's what I'm not getting. Is there
It's
both
like a
or is it just
purplish.
the one?
Here, let me see. It's like let me see. Let me show you a good picture.
So for a select mode apply question, would they
What?
both be cyanotic?
Hold on. Let me see. Let me see. I have a hard time. I'm looking for a good. And you know what? All I can think of is like during the summer when I start looking at everybody's feet. And I know that's bad. Okay. And I wouldn't say it's cyanotic, but it does have a bluish hue to it.
So like if it is a multiple choice question, are they both cyanotic or is that just, should we focus that more on the PAD?
Hold on. Let me see if this pulls up. This isn't the greatest of pictures. And I would like, if you're looking at somebody, can you see that? Okay. You see how it's kind of bluish hue, but
No,
it
we-
has, can you
There
see?
it goes.
Hold on. I don't care about learning how to take care of wounds. No, get out of here. Okay. These people just don't let me steal their pictures. Okay. You see how it's kind of bluish? Oh dear Lord. It has a bluish but it's hard to describe. It has a reddish bluish tint to it. Now this is peripheral vascular disease, okay? This is venous. The foot's a little bit swollen, right? But you see how it's a dark bluish purple. I would say it's bluish purplish. Okay. Now, if we would go for PAD. I'm sorry, guys. Ah, that's not what I was looking for. Oh, I'm sure glad that I have. Oh my God. Oh my God. Okay, note to self, don't. Okay, there we go. Okay, I'm glad we can stay dry. Let's find some good PAD pictures. With PAD, you're not going to have that swelling. Legs. And of course, I'm not going to find any good leg pictures, right? That's my PVD picture. Okay, see, nice thin legs. I can't find any ones that I'm really talking about. I can't find any good pictures, guys. So for the test, which is probably what you're more worried about, right? Than the actual pictures. You're like, yeah, why are you wasting my time? Okay, for the test, consider PAD cyanotic. PVD would be rubor. Let's just stay with rubor. Okay.
Can you repeat that?
So with PAD, we're going cyanotic. With PVD, it's going to be rubor. And I'm going to find some really good pictures. And they're not going to be as sanitary pads either. I am so glad there's no guys in this one.
What about this? I don't know if you can see it well or not, but like this picture.
Okay, let me see. Hold on. Oh, I did for a second. And did you just put PAD on that one?
I looked up peripheral artery disease.
Oh, yeah. You guys probably can't see it either. But you see right there towards the bottom by the ankle how it's discolored? Yep. And it looks more, it doesn't look as deep as a color. It's kind of like just on, and how you explained it before, Veronica. That it's just, I don't want to say facial, but superficial. But for the test, yeah, I got to look for those pictures. For the test, we're going cyanotic for PAD, and we're going to go rubor for PVD. If you had the difference between the two, like if you were at Target and you looked at the difference with the two, really what you're going to be looking for is you're going to see the swelling of the patient that has the PVD.
I feel like PAD it looks more splotchy than PVD does. It kind of follows the capillaries.
Yeah,
if that makes sense.
It makes sense because PVD, the whole foot looks bad.
You know, I found a really good one of the PVD, Becky. It's I wish I could show it. It's not letting me, but like it goes up like the whole leg and it's super dark. I get it now.
Okay. I'll have to be more prepared next time. I wasn't prepared. And I guess because it's in my mind's eye having to take care of, and you guys probably, if you're in nursing homes, long-term facilities, you probably have seen plenty of patients that have PVD. You know, I know when I first got out of nursing school, I was I was hell bent that that patient was not going to have any more scaly skin because I was going to put that much lotion on him. And guess what? I just wasted my time because as soon as you put it in, it just sucks it dry. I don't understand, but anyway. Okay. So we did manifestations. What's some education to our venous patients that have PVD?
Discourage prolonged sitting and standing.
Right.
Compression socks or TED hose.
Yes.
Frequent elevation throughout the day and night. And
Yes. Remember with PVD, the legs go up. PAD, the legs go down. Okay. Compression hose. Do we want compression hose on our patient? So would we put TED hose on our patient that has PAD? Oh, I got you guys thinking.
Can you
No.
repeat the question?
Would you want to put TED hose on your patient that has PAD?
I was talking to Karen about that, and I think she said, unless I misheard her, I think unless like they're having an acute episode, but overall you would want to avoid it.
Avoid what? Putting TED hose on them?
For PAD.
Yeah. So why would you not want them to have TED hose?
Because
You want
it's
them to
constricting.
die from having a DVT?
No.
I would say yes, because there's a lack of blood flow, so you would want to get the like circulation going again.
So you would put them on for a patient with PAD?
Yes, I think so. I don't know. I get them confused so much.
But since PAD can't feel their foot, would that be a good idea? Like they can't feel their feet very well. Would that be a good idea? Because they wouldn't be able to tell like if they're losing circulation.
Oh. What about some of you guys, other guys?
I feel like it would constrict it even more,
Ah.
not allowing the blood to get down there at all.
Exactly. So if you have a patient that has PAD, they're already having issues with getting their blood flow down to their feet, right? So if we put compression stockings on or TED hose, it's going to even further constrict them from getting blood flow down. So it's probably not a very good idea to give them TED hose. Okay, we want to stay away from that. It was a trick question.
So I want to make sure I understand this right. For elevating the legs, we want to keep the legs dependent with PAD and elevate for PVD.
Right. So
Okay.
think where the blood's having a hard time getting to. In PAD, it's having a hard time getting to the feet. So you're going to help them, you know, gravity helps, right? So we're going to help them by lowering the feet. In PVD, it's having a hard time getting back to the heart. So we're going to help the blood a little bit by lifting the legs so it has an easier time getting to the heart. Okay? Just think about what's going on with your patient. Where does the blood have to go? Or where is it not going? It's not going to the feet. So we're going to do everything we can. So we're not going to tell our patients to wear, I don't know, anything constricting going down. We don't want them to wear athletic socks that come up to their calves. Okay. We want them to wear nice loose clothing that allows that blood flow going to the feet. On the other hand, with our patient that has PVD, we're going to ask them, you know, wear compression socks, TED hose. Okay, but we have to be careful with those TED hose because if they are if they're small and they're using a large TED hose, is that going to do any good? You know, or if they were, say they were on 600-pound life and they had the surgery and they lost 100 pounds, you know, what's a priority that we have to make sure that we have to do? Well, we got to make sure that that TED hose is still that same size. So we'll probably have to remeasure them to make sure that it's not too loose. So it's just something something to kind of think about on those aspects.
So for PAD, we're giving them, we would anticipate giving them antiplatelets, and that's going to help prevent the blood clot instead of the TEDs, right?
We would give them antiplatelets. Okay, so we can give them antiplatelets. Is that going to guarantee that they're not going to have an arterial occlusion?
Well, nothing's going to completely guarantee it.
Exactly, unless we gave them a thrombolytic. But then we don't want to do that either. So yes, I mean, antiplate is going to help, but it's not going to cure. Nothing's going to really cure them. I mean, we can slow it down by telling them to not smoke, eat a low-fat diet, exercise, but it can slow it down, but it's not going to stop it. Okay. I have to stop saying that. Okay.
Is an Una boot just to like constrict?
So what an Una boot does is it's like a cast, and it helps get that blood flow back up to the heart. We generally put Una boots on patients that have venous stasis ulcers. Okay. Because it has, I don't know what they put in it, but it helps heal those venous stasis ulcers.
For PVD.
PVD. Yeah, Una boots definitely would not help with the PAD patients. Do you guys understand the difference between PAD and PVD? Just, think of the plumbing, where it has to go. I think if you think about it, it'll be a lot easier if you can rationalize it. I think it's a lot easier than just memorizing the whole procedure, what's going on with it. So we talked about venous stasis. And what medications do you think those folks are going to be on that have PVD?
Anticoagulants.
Definitely anticoagulants. And that's probably the biggest one they're going to be on is the anticoagulants. Because we don't want them to have get a DVT.
What's the Burroughs solution?
It's like an antiseptic that we do to help heal help heal the venous stasis ulcers.
So is that like the same as the topical steroids and the antifungals?
Yes.
Anti what?
Fungals.
And this is for PVD, right?
Yes.
Okay, thanks.
Okay. What do you think?
I have a question back up on 12, like when we're talking about the arterial occlusion versus venous thrombus. Because for arterial occlusion, it says that we give IV heparin, but you said that we give antiplatelets and not anticoagulants.
Okay. For an acute occlusion, we would give heparin. If it's managed like they're going home, we're going to give antiplatelets. Okay, because we want that blood thin enough it can go around, and what we don't want to happen is if it's a cause because of platelets, aggregated, we don't want a blood clot to start forming behind it. So that's why generally, so what would you say? Chronically, we would do aspirin and Plavix and Agrigox and things like that. No, Agrigox is IV, not that. I was thinking Effient. But chronically, we would do that. But if it's acutely and it's an occlusion, then we would turn around and do IV heparin. Because we got to get that blood flow to the leg. If we don't, then we're going to cut it off.
For an arterial occlusion, right?
Yes. Well, and quite honestly, for a DVT, we're going to start a heparin anyway. What do you think? Oh, I got 2 thumbs up.
So do we need to study more than just the study guides? Because it pretty much covers the slides.
Okay, to answer your question, there's not going to be any EKG strips on the test unless you want them. You guys are no fun whatsoever. Okay, no EKG strips. What I did when I did these study guides, I went through the slides and I picked the information that is relevant. So if you notice through these guides, I didn't pick like what kind of antibiotics would you use for this, right? Or trying to think some of the other things I didn't pick because I'm not going to test you on that. So the way I would study, I would go through the study guide and see what I know, what I don't know. Use your flashcards, quiz yourself, have somebody quiz you, whatever it is. But make sure you know the information. Don't just look at the information and say, yep, I got it. Because I guarantee you when you're taking the test, you're like, crap, I don't have it. Okay. That's one thing. Everything. If you don't understand something on the study guide, go through the slides, go through the book, whatever you got to do to get that information solidified in your head. Okay. Or you can email me or text me, but don't text me after 10 o'clock. I kind of get pissy about that.
How early can we text you?
That's rude. For tomorrow, 7 on a Saturday or a Friday, 8. I mean, I'm up, but I kind of want, my time, to just chill. So like 8ish, generally 8ish is a good time. But tomorrow, because
Okay.
it's a test, 7 o'clock is fine.
Thank you.
No problem. So that's how I would study. I did put up, I don't know if you noticed, on ATI, there's heart failure, inflammation, and PVD test. What I've noticed is that people that have gone through that test a couple of times have done better on tests than those that don't. And this is my feeling on it. My feeling is that if you go through the test once and you get a 65%, and you look at the rationale, and then it's just like anything else, you're like, oh, I got it. But do you really have it? So if you go through it again and test yourself again, if you get that question right or wrong, that really shows, do you know the information? Does that make sense? Because for me, I can read some, I'm like, yeah, I got this. But then I'm like, oh no, I really have to read it. If you go through it a couple of times and you understand the rationale, then by the second time, you should be able to get a 90 or above on that test. But see if you go back and test yourself again and see if you really do understand the information. You really know the information. Okay. If you do it once and you get a low grade, well, do you really know the information? So that's my philosophy on that.
So for those quizzes, would you recommend obviously taking them and retaking them again? But after we think we have a handle on that, should we retake those or do the learning systems? Which do you think would benefit us better?
So retake that one again?
Yeah, or do the learning system 3.0?
So I would go through so if it was me, I would go through ATI, see what I knew, what I didn't know. What I didn't know, I'd mark down, and then I would investigate it. Because obviously you don't know the information because you got the question wrong. Then I would retake the test. Okay. I'm not really that familiar with the learning system 3.0. because that breaks it down into systems, correct?
Yeah, it does.
Yeah. So I would say if you were still struggling at that point in time, then I would go to 3.0. I got to get more familiar with the 3.0. It seems like a lot of ATI stuff is really good for fundamental stuff. They have a lot of stuff for fundamental, but once you get into like third semester, kind of like weighs off on us. Doesn't have as much information, not as much applications that we can use. Does that make sense? I know I always say,
Yeah,
I say, okay, or does that make sense? But that's how I would do it, but everybody's different. But make sure you know where your mitral valve is. Make sure you know where your aortic valve is. And if your mitral valve is not working, where is the blood going to go? Okay, don't overthink it too much.
So there's only
Well,
that
they-
one test on ATI, right?
I think so. What are you 521 or are you 1021? When are you graduating? In May or in October?
I'm May.
Okay. So I'll have to look. There might be another test on there. So because I have usually 2 different cohorts, like some of you guys are graduating in May, some of you guys are graduating in October. So I had tests or quizzes. I think I have retakes on there from my last 8 weeks. Let me look to see. If I do have anything else on there, I'll let you guys know.
So I don't know if this is being too greedy, but do you think that you might have pictures where we label things on this test, or am I being too greedy?
Do you think I think you're being too confident in my ability for technology. Because I don't know
That's
how
a
to
good
do
point.
that. If you want, I'll throw a calculations quiz on or calculations on there.
That's a good idea.
Yes, I like that.
Okay, because I can do that. But yeah, labeling, I haven't figured that one out yet. There's different ways we can do things like matching and all that, and I haven't figured all that. You never know though. Maybe I could do a matching with P. Oh, I can't tell you because I'll get you. Okay, forget it. Anyway,
But that would be a good idea for the future.
Holland's like, oh hell no, just give me calculations. Give me calculations. Okay, so if you have any questions, I hope I gave you a little bit of how to study for it. I am being very careful. I'm on this quit test to make sure there's no doubles and there's no triples, and you know, it's a very good quiz or test. Sorry. There's not too many select all apply either, and I apologize about that. I know you're going to be heartbroken. But if you want, I I'm a people pleaser and I will put more on there
Nope.
to make you happy.
Nope. Please
A good
no.
alternate question would be a short answer about how much we love your class, and that could be extra credit.
Oh my God, she kisses ass and does at the same time. She advocates for the class and kisses my butt at the same time. That's multitasking. Okay, guys. For anybody that just to let you know, if anybody asks, I did tape it. It takes a while because Zoom, it converts it and it takes about 45 minutes to an hour to convert it to an MP4. Then I have to upload it to YouTube, and then I have to once I give you the link. So if anybody asks, it will take a little bit for me to get it down to you guys or them. You guys don't have to listen to it again because you've been here.
So to be clear, we should focus on the study guides.
I would look at the study guides, because then why else would I put them on there?
I'm just, making sure I don't have to go back through the slides or anything.
I mean, should we focus on some things that aren't, because like you didn't have like Marfan syndrome or anything on the
No.
study guide, so I didn't know if we had
No,
to focus on that for the
no.
test.
Stay away from Marfan syndrome. I put it on there just so you knew what it was. Okay. I put pulsus paradoxus just so you know what it was, but I'm not going to test you on it. Okay. So that's why when I said that study guide is like this skinny down version of, I went through and saw what was important, what you'll be tested on. Okay. What you'll see. I've only saw one person had Marfan syndrome. Okay.
Thank you for doing the study guide.
What?
Thank you for doing the study guide.
No, no problem. Sorry it took so long. But I really wanted you guys to understand what was going to be, what was important, and, pull some information that you would have to, that you'll need to know, and that you'll see on the floor, and that you'll deal with. And that will be on NCLEX. If you get an NCLEX question about Marfan syndrome, that's all on Lisa Ring, man. That's not on me. Okay? Because that's her, well, I don't know. Where would Marfan syndrome come from? I would imagine it would be with her because it's connective tissue. Okay? So study guide, but use those slides if you don't understand everything that's on that study guide. Or use your book. Use everything but WebMD. Or Wikipedia. Is it Wikipedia? Don't use Wikipedia. Is even the thing anymore, Wikipedia? Oh, it is. Okay. Okay. You guys good? Okay. Now you've been sitting here for 2 hours. Get up, walk around, get something to eat, except for Logan, because she's been eating this whole time. But anyway, okay? And let me know if you have any questions.
Your dog is breaking my heart.
Oh, look at him.
It hurts my soul.
You can't really see him real well, but he has his little sweater on, and he has his little bow tie.
Oh.
He looks like Ducky from the NCIS. He's the only one that hasn't been cut yet.
That.
He's so cute.
Well, he's happy because he didn't go have surgery today. Only 2 of them did.
Mm.
But it's only
I hope his name's Ducky.
What?
I hope his name's Ducky.
No,
I
it
don't care
isn't.
about his real name.
No, his name is Max. He's Maximus because he's so small. But my other Chihuahua, the female, I guess she was in heat, and they were all after her. So they kind of got snipped today, and he's the only one that didn't. So he goes on Christmas, December 23rd. Merry Christmas to him. But anyway, okay. So let me know if you need anything. Okay. See you tomorrow at 8:30.
Thank you.
See you guys. Cancel. I gotta stop recording.